Hello, everyone. I'm Dr. Andrea Durst. I'll be introducing this session today. Welcome to the concurrent session on evaluation and quality improvement in genetics, applications, and resources. This afternoon, we'll be hearing from Dr. Melissa Raspa and Oksana Kutsa, who are evaluators with RTI International and a vital part of our NIMAC leadership team. I'm excited to hear their presentation, and so I will go ahead and turn it over to the two of them at this point.
Great, thank you. So I'm going to do some slide sharing today. So just give me a second to pull those slides up and we will jump right in. Okay, are you guys seeing the right orientation or do I need to flip it?
It needs flipped. We're seeing
okay, let's switch it up into. Okay, thank you. All right. Well, thanks for the warm welcome. Oksana and I are going to do a little tag teaming today and kind of walk you through some intro and kind of activities around quality improvement in genetics. So we're going to have some activities to do and also be sharing some resources and talk to you a little bit about how quality improvement's been used in the not only NIMAC, but the broader RGN network. So excited to have you guys here today. So no financial disclosures for either of us as our required slide here from ACMG. Okay, so before we jump into content, we, like many of these presentations, wanted to get a sense for people's kind of level of experience with quality improvement. So I think either Erica or Fred or one of our tech gurus is going to pull up a poll here. So this is our first poll question. So if you can enter it into the poll, great. Otherwise, you can always put it in the chat. But basically, we want to know how familiar you are with different approaches to quality improvement. So anything from not at all to a complete expert. So we'll give you a minute here to answer.
All right, we've got most of the answers coming in. So I'll end the poll in 3, 2, 1. And here you go.
Awesome. Okay, so a range. We've got not quite 20% who are pretty new to quality improvement. You'll get lots of out of this presentation. Same for the folks who know a little bit and even somewhat. So if you're an expert, you can help us along the way and add to anything that we leave out. So we're excited, like I said, to kind of give you a little bit more information about it today. Okay, so one more poll before we move into the content. So question number 2 is, have you actually used any quality improvement approaches in your work? Yes, no, or not sure. There's the poll. Thank you. Give folks just a minute here to respond. Hopefully it's a quick one.
Fast answers on this one.
All right.
All right, so I'm going to end it in 3, 2, 1. And here you go, Lisa.
Oh, great. We've got 50% who've used some quality improvement. Fantastic. 25, and then a bit of a split between no and not sure. Okay. Well, if you are new to quality improvement, like I said, we'll give you some good information, overviews, and resources and tools to kind of get you started. And even if you've, like I said, got a little bit of experience or are really experienced, hopefully this will be a good refresher, or you might even learn something new. So let's dive into the content. Okay. So if you are fairly new to, like I said, to quality improvement or even evaluation in general, you may be familiar or have heard of many of these terms before. They often get used interchangeably. Sometimes there's confusion over what do we mean when we talk about quality improvement or evaluation. So I just wanted to kind of run through a few of these and let you know kind of how we're going to shape our conversation today and where we're going to focus. So really, we're going to focus on those first two, quality improvement and continuous quality improvement. So that's what we do a lot of in NIMAC and in the regional genetics networks. So that's really what we want to kind of share with you today. Some may be familiar with the words quality control or quality assurance, or even process improvement. Those again are quality related activities or even processes. Oftentimes like QA and QC are used either in the lab sometimes, or sometimes in manufacturing, like very product oriented fields. And quality control is really kind of how do you control for quality during the process. And then quality assurance is how you go back and double check. Did we do what we were supposed to do? And of course, process and improvement is related to that, where you kind of think about how can we improve our quality control processes. Process evaluation and program evaluation sound really similar too. Process evaluation is kind of a bigger picture component, if you will, of what we're going to be talking about today. And program evaluation is similar in the sense that it's also, again, an evaluation, but usually around specific programs or like a specific project, a specific activity. So we're not going to go into too much details about those today. And then the last one actually doesn't have quality or evaluation in the title, but you may have heard the term implementation science. And implementation science is, again, kind of a broader field about methods around how do we kind of implement things, how do we measure things. But again, we won't really be diving into that today. So like I said, we're going to focus more on those kind of top two, which, like I said, are often interchangeable: quality improvement and continuous quality improvement. So the definition that we wanted to share with you, which we thought was really helpful about quality improvement, comes from the U.S. Department of Health and Human Services. So hopefully you hear some kind of things in this definition that resonate with you in your kind of group, whether you're a genetic counselor or a patient or a family member. But here we're using the definition of quality improvement as systematic and continuous actions that lead to measurable improvement in healthcare services and the health status of a targeted patient group. So we just wanted to kind of point out a couple of those key things that we think are really important as part of that definition. So first of all, quality improvement is really systems oriented. We're talking about all of healthcare services here, a big picture system. It's also kind of similar to what I was saying about kind of quality control and quality assurance. It's a very proactive approach. You don't just want to look at quality improvement after the fact. You want to kind of plan for it along the way. And we'll be talking about one specific method here in today's presentation. I think another really important thing to keep in mind with quality improvement is that it's okay, both that third bullet and that last bullet, that there are errors. That's the whole point of quality improvement, is kind of identifying errors, realizing that it's okay, but then really taking up, like I said, a proactive approach to try and address those errors. And then finally, given that it's that big picture kind of systems approach, it almost always involves a larger team, right, of people. It could be kind of a small group who starts with quality improvement, but hopefully eventually it hits that systems level and is really kind of that broader team. So we'll be keeping some of those things in mind, like I said, when we get into some specifics here about how we can use quality improvement in genetics. But before we do, I want to hear from you all and see, especially for those of you who may have used some quality improvement already in your kind of day-to-day lives, hopefully in genetics, or maybe in your broader kind of patient care. Why do you think quality improvement is useful in the work that we all do in genetics? So just feel free to enter some ideas into the chat. Okay, seeing some answers come in. Great. QI is a requirement of ongoing certification. If you don't measure it, you don't act on it. I love it because we aren't perfect. I love that. It's a great attitude to have. Understand if we're meeting patient needs. Excellent. Yes, constantly evolving or changing field helps us serve our patients better. Awesome. Great. You guys have already thought about some really interesting applications for quality improvement in genetics. So keep some of those in mind. We are going to use some examples throughout today, but then kind of towards the middle end of the presentation, we'll be kind of sharing around kind of all kinds of different ways that you can use quality improvement in genetics. So thanks for sharing. Okay. So that was a quick overview. Now that we've got you warmed up, we want to actually shift gears and talk and really do a little bit deeper of a dive into, like I said, one particular way that we often use around a method or a specific approach to quality improvement. So for the next 15-20 minutes or so, we're going to focus on the PDSA cycle. So the PDSA is an acronym standing for Plan, Do, Study, Act. You can see by the graphic there on the right, it really is a continuous process. You start with the plan, trying to identify what we're going to accomplish and what we can change, where we really want to make those improvements. We then implement the plan and really head into the do kind of box there. We'll be looking at after that, the study box, which is kind of understanding how did that implementation of the plan go. And then finally, we end with the act box, which is trying to do an assessment of what are we going to do with the findings and kind of figuring out where do we go next. So we're going to talk about each of these here now in a little bit more detail. Okay, so starting with the plan. This is really, like I said, that first step in the PDSA cycle. It's really probably where you're going to put a lot of effort to kind of get things going. And we're going to do an activity after we kind of run through a couple of slides here together so we can kind of get the hang of it, if you will, around what are some great ways and tools to help you as you kind of come together and make a plan. So here I've got listed a couple of those kind of key sub areas that you'd be focusing on in the plan stage. Certainly first and foremost, we got to identify who's going to be involved in this PDSA cycle or in the quality improvement, what organizations is, like I said, starting small, who's going to be involved first, where would we think about expanding maybe eventually. Certainly need to think about the quality improvement target. So brainstorming areas of actually needed improvement or gaps in the system. Sometimes people come to the table and already know, oh, we've got a problem here in this specific area. They've really already identified the need, but maybe they don't actually know what's under that kind of third bullet, the root cause, like, hey, we've got some things going not ideally in the clinic or in our genetics practice. Here's some things that we need to kind of think about and identify that root cause analysis. So we'll be talking, like I said, in a minute here or two about a little activity to help us kind of think through with an example of how we what tools we can use to conduct a root cause analysis. After you've done that activity or kind of reviewed all the available data, done that brainstorming, the next step in the PDSA or in the next step in the plan box or part of that PDSA cycle is to kind of select what you want to improve and then finally develop some SMART objectives. So we're going to go into a lot more detail here. This is just this kind of big picture about what we want to cover in that plan stage. So here are some a little bit more information about that root cause analysis. Like I said, sometimes people kind of already know what's kind of going on and figuring out, oh, we got to do some quality improvement here because X, Y, or Z is not working well. Sometimes you really know kind of what's the main trigger. I mean, what is the main issue that's causing that kind of a need for doing some quality improvement. And other times you might need to kind of take a step back and kind of look at it holistically and do what's this described here as a root cause analysis. So part of this process is really helping you to define the problem, kind of getting a better understanding about what's happening, what are the problems you're trying to solve. Like I said, trying to assess the bigger picture scope of the problem, like do we have proof that that problem exists? How long has this been going on? Who's been impacted or what's kind of the major issue here, kind of the impact of that problem. And then the third area of the root cause analysis is identifying potential causal factors. So why did that problem occur? What are some factors that are kind of related to that problem occurring? And then next is what's really kind of looking at that whole breadth of those different possible causal factors. What's the main problem that you think is really kind of the cause and the one that you really want to target in your PDSA and a quality improvement plan. So that final step is then kind of reflecting on all the data that you've collected and really recommending and implementing some possible solutions. Like I said, kind of the target of that plan. So like I said, the root cause analysis really allows you to kind of go through this process in a pretty systematic way. And thankfully, we've got some tools, and we're going to do some breakout sessions here as soon as I kind of introduce the tool so you guys can practice a little bit. Okay, so my favorite tool for using in the root cause analysis is what's called a fishbone diagram. So we've got an example, a template here of a fishbone diagram here up on the slide for you all to see. It does indeed look like a fish. So just to kind of walk you through what's here. So the head of the fish is the problem. This is what you're trying to solve. Here, kind of in the branches of the fins or of the scales, are the different types of causes that could be potentially creating that problem. So here we've got a couple of examples identified. It could be things like personnel that are causing the problems. It could be we've got some methods that we need to improve, or processes of how we're implementing something that is really the problem. Kind of how we're measuring things. Maybe we have the wrong tool or way of assessing how we know if it's a problem. Different materials or machines. That could also be equipment that, again, are kind of potential factors that are causing the problem. Or is the general environment part of the problem, like the location of an office or something like that? So those are the big kind of categories or types of causes, but then those individual lines are what is called this, kind of specific causes, if you will. So let's kind of think about how we can apply that fishbone diagram in genetics. Okay, so the example that we want to try and use is for today's breakout session is missed genetic appointments, right? Everybody who has either been a patient or a family member themselves or in a clinic as a genetic counselor is probably familiar with people missing genetic appointments. Maybe you've done it yourself, or you've had a patient that has been who's missed a scheduled appointment. And there obviously could be a lot of different reasons behind missed genetic appointments. The problem is, though, oftentimes in genetics, there's a long wait to get into genetics appointments. It's inefficient, right? If the genetics staff have gaps in their day when they could be seeing other patients. So the goal for this, kind of activity is really to kind of think about how can we minimize or reduce the number of genetics appointments in order to kind of make sure that this is being, like, for example, a genetics clinic is running pretty efficiently. So again, some of those potential factors that could be related to a missed genetic appointment could be family or patient reasons. Maybe somebody got sick the day of. That could be a specific reason that could go underneath the individual line under the patient or family, and that was the reason why they missed the appointment. Some environment things could be causing a missed genetic appointment. Maybe it's a clinic at a university and it's really difficult for a family to find parking to actually get to the genetics appointment. So that could be, again, an example of an environmental cause. Insurance, that might be a cause, patients not knowing if the appointment's going to be covered. There could be some provider or clinic level things that are really gearing towards missed appointments. Or like I said, oh, I've got environment twice. Sorry. I think it was supposed to say measure somewhere. So, or methods. So maybe the process of getting in the door wasn't quite clear, or the patient forgot to do paperwork or something like that ahead of time, so didn't want to show up at the appointment without their paperwork. So like I said, there could be lots of different reasons for missing a genetics appointment. So what we'd love for you guys to do is to kind of use this example and dip your toe, if you will, into the waters of quality improvement and root cause analysis using this fishbone diagram. So in just a moment, we're going to send you out to breakout rooms. I think they're going to be random, so you'll see that come up on your screen. And in those small teams, in those work groups, you can, I think we'll be able to carry over, if I'm not mistaken, the fishbone diagram for you guys to see. And what we'd love for you to do is just use about 7-8 minutes or so to really start brainstorming some potential specific causes under each of those different areas or types of causes around missed appointments. So like I said, you can brainstorm around family or patient causes, provider causes, the clinic or environment, or even insurance. So I know we probably didn't give you advance warning, but if you can write down a couple of these ideas, we'd love for you to report back when you come back to the group. And like I said, about maybe like 7 or 8 minutes. And one of the things while you're going through that brainstorming activity is if you can kind of think through with your group, maybe what's the main cause, if you can, if you've got time, and we can kind of make note of that when you report back. So hopefully that's clear. You guys have some good marching orders, so you guys can jump in. I see if the the breakout rooms pops up on your screen, go ahead and shift over and join those meetings. Can I start screen sharing again?
Yes, you can.
There we go. Okay, let me pull up those slides again. Hopefully you guys had a good breakout session and are getting ready for report out. Okay, so let me click to the next slide. I think what we're going to do for efficiency's sake is use the chat feature. Given that we've got lots of people and it might be hard to kind of manage verbal report out. So we're going to take each of these bullets in turn. So if you were the reporter, or even if you weren't the reporter and feel bold, you can go ahead and start in the chat, and we'll start with that family and patient causes. So go ahead and list in the chat some of the things that you guys thought could be patient or family causes for missed appointments. Let me pull up in the chat so I can see it. Okay, we see the responses coming in. Unexpected illness, yep. Anxiety over the appointment or previous difficult encounter. Unavailability of spouse or family member. Telehealth requires the presence of the patient. Great, all good ideas. People aren't actually interested in genetics, but agree to the appointment. Yes, you guys are hitting on a lot of things. Patients not seeing telehealth as a formal appointment. No reminder call. Great, these are all awesome potential root causes. All right, keep them coming. But if you want, we can switch gears to provider causes. So I didn't mention this before the breakout, but you could think about both referring provider causes for folks who maybe didn't get the family or the patient to the right genetics location, or from the genetics provider side. What could be some reasons for missed appointments on that side in that area? Again, great, no reminder calls. Yes, provider doesn't have actually enough appointment slots available. Providers pulled in too many directions. Perfect. There was a need for more genetic counselors. Great. These are all terrific ideas. Yes, referring provider not explaining why the referral is needed. Perfect. Okay, let's move on to, we can do two. How about both clinic or other kind of broader environmental causes? And by environmental causes, like I said early on, it could be like the location of the clinic. So let's take those together. Not enough clinics, no parking or traffic, great, bad weather, Clinic not in a public transportation area, long wait times. You guys are pros thinking about all these possible causes. Distance from the clinic or home, having to pay for parking, yes, another great potential cause. Okay, then let's go through the last two bullets there, some insurance causes or any other causes. Go ahead and feel free to add those to the chat. Anything else that you guys touched on in those two categories. Cost, yep, out-of-pocket costs, genetic testing costs, lack of referral from your PCP. Yes, nobody realized that the insurance wasn't, a pre-authorization wasn't gotten before the appointment. Yep, out-of-network charges, very similar. Worry about it affecting future insurability. Ooh, that's a good one. All right. Well, you guys are already pros at the fishbone diagram. I'm very proud of you. Well, in the interest of time, we're going to just kind of quickly move on and talk about, we actually did this project as part of the NIMAC team. So I wanted to share with you, and you guys have already hit on many of the things that I've just pulled up in this chart. But here we did a survey a couple years ago around missed appointments in general, knowing that it was kind of a big problem area for some of the clinics in the RGN. And here's what we found. You can see there in that top right-hand box, we actually did a survey of patients and families, and here's what they reported were either not a reason at all, so a score of a 0, somewhat of a reason was a score of a 1, or definitely a reason was a score of a 2. And you'll see a lot of familiar things here from what we just saw in the chat. Wait times were really long, or the patients either didn't know what to expect or were worried about getting test results, didn't know about costs or transportation. Some other things kind of more logistical related around trying to find childcare, or too busy, couldn't get off of work to attend. And then that one of the kind of biggest driving areas that we saw, or biggest causes, I should say, was that the office was too far, right? So we use this to help us kind of think through our plan, which is step 2 of the PDSA cycle. So we'll be returning kind of to this example for the next few minutes so we can kind of keep it in mind while we move through the rest of the presentation. But the next step, like I said, in that PDSA cycle is step 2. After you've made the plan, after you've kind of done the root cause analysis, you create the plan. So we're going to quickly just chat and check in about those SMART objectives. Again, you can see there the graphic on the right. SMART being an acronym for specific, measurable, achievable, relevant, and time bound. So I'm going to give you some examples here on the next page. But I just want to call out one of those things to really, again, I referenced that kind of earlier in the presentation to keep in mind. Really, when you're thinking about that plan, really start small and then eventually scale up. That's kind of one of the key steps kind of later on. So here's just an example of, again, part of a plan that you could implement, again, around decreasing missed appointments. So here we've got outlined in the left-hand column our SMART objective. So by July 2023, we will reduce the number of missed appointments in our genetics clinic by 20%. That's a very specific, measurable, achievable goal, right? Here are some other things, like I said, that you want to take note of, making sure you know, okay, what's our target activity? What are we going to do to address and achieve this objective? And based on our root cause analysis, maybe we decide we're going to educate patients and families on what's the reason for this genetics appointment? Like, why were you getting referred in the first place? The people who are going to be responsible for implementing this plan are Naomi, the scheduler, Dr. Avanti, who's the geneticist, and Roberto, our genetic counselor. These are obviously just fictitious names. Some of the resources that we're going to need, clearly staff time is going to have to be set aside to actually implement this. And also we're going to need something to actually educate families. So we're going to go ahead and, in this example, develop an educational flyer, let's say, to really help, like I said, those patients and families understand the need for the appointment. And then finally, how are we going to track or measure how well this plan's going? We're going to create an Excel file, and we're just going to kind of keep track of how many appointments were missed each week. So I just want to quickly talk a little bit about measures in particular. Measurement is kind of one of the key, obviously, ingredients in developing that plan. And I just want to kind of clarify about 2 different types of measures. There's process measures, and then there's also outcome measures. So starting actually with the outcome measures are actually the things that you want to keep track of. So in our example here, it's the number of missed genetic appointments. That's our outcome, right? That's what we want to try and target. We want to reduce the number of missed appointments. But process measures are also really important, right? We want to try and understand, how did our plan go, right? Are we doing a good job implementing the plan? So those are types of things that really kind of add to the bigger picture when we get to that study stage of the cycle, which is next. And really, there's no like one specific way to track or measure or collect data. You can use a checklist, you can use surveys, you can use a tracking spreadsheet, or you can simply just kind of reflect and have some observations. So all of those are totally acceptable, different types of measurement approaches. So let's jump into the do stage of our PDSA cycle. Once we've got our plan in place, we've got kind of our SMART objectives, and we know who's doing what, we're going to actually implement that plan. So part of that, of course, is actually doing the specified activities, collecting that data. Things to keep in mind, again, in continuous quality improvement, you want to try and have some data points to help you. So 8 to 10 is usually kind of the minimum number of data points that are recommended to kind of get a sense of how well our plan is working. And then, of course, like I said, part of that process assessment or things to be measuring are things like, how are things going? Do we think we're going to eventually need to make modifications to the plan? Or, you know, kind of overall, what's our feeling of kind of success, or were there challenges? So looking at that missed appointment data, here again is just a great chart. On the y-axis there, you can see that's the number of missed appointments. And then we've got just kind of some examples of the data that was collected by the hypothetical team here for 12 weeks. And then that green bar is kind of our goal, right? It's our SMART objective. We want to reduce it by 20%. We want to get fewer than 6 missed appointments per week. So when we sit down and have that data in hand after, like I said, our 8 to 10, or in this case, 12 data points, we really want to study those results. And here are some kind of key questions that should help kind of drive the interpretation and the analysis of that data. So we first want to be looking, were there any patterns in the data? You know, did we actually meet our goal? And then overall, kind of what did we learn? What was our big picture takeaway? So again, revisiting that slide, here's some questions that we might want to ask when we're kind of reflecting on the data in our group, our implementation group. Why did it take 3 weeks for us to get kind of below our target, right? We see here in this pattern, we had 8 and then 7, and then we bumped up to 9. Missed appointments in the first couple of weeks of implementation, but then we saw this nice pattern of some reduction in missed appointments. So a question we might want to ask is, why did it take 3 weeks? And, you know, a quick and easy answer to that one could be, well, some of these appointments were scheduled ahead of time and we didn't actually have the chance to implement the plan right away. So not surprisingly, it might take a little bit of time. But then other things that we might want to take a note of, like here in week 10, here we had a little hiccup, you know, we were doing really good for several weeks, and then we had a bump up here in week 10. You know, what happened? What could be causing that bump up? And, you know, maybe the scheduler was out on vacation that week and we didn't make a good enough plan for how we were going to send over all that great educational information. So we actually saw a bump up maybe in that week because of the scheduler being out. So finally, the final step there in that PDSA cycle is that act. You really want to use this to act on the results, and if needed, make some changes to the improvement plan. So these are the 3 A's to keep in mind as you're kind of drawing conclusions from your cycle. Adopt. Do we want to adopt this plan? Did it work? Can we go ahead and start thinking about scale up? Do we need to adapt it? Were there a couple of tweaks that we need to make? For example, like the scheduler, we need to make sure we account for when Naomi's out on vacation, right? So what are the little tweaks we need to make? Or abandon? Did it just not work at all? Did we not have the right root cause? Did we not have the right plan? Were we too ambitious in what we wanted to do? And here are some things for that adapt that really could be common problems that you might see kind of driving why you might be abandoning the plan, or you might need to kind of rethink those SMART objectives. Like I said, the outcome maybe wasn't measurable. It was too big. We started too big. We didn't start small. Maybe the measurement approach was too broad, like we weren't going to be able to see change as quickly as we thought. Did we really not have enough information to kind of draw a lot of conclusions? Or was the data really not interpretable? Did we see like too many different things and we weren't really sure what to make heads or tails out of it? So those are some common problems that you might see in PDSA, but not to worry, you shouldn't abandon ship. So I think in the interest of time, I'm going to skip the last poll question and then just quickly go through a couple of resources so that Oksana's got plenty of time to present some of our current work. But here are just a few kind of takeaways that I want to leave you all with. It takes a village. We hear that all the time for most things in this life, but a champion is really helpful. You really do need somebody who can really be the champion and make sure that the train is running on the track and that PDSA cycle is really kind of moving along. Thinking outside the box is totally fine. It's where you're going to get a lot of bang for your buck sometimes. But also on the counter side of that, you can realize that it's okay to fail. There's always lessons to be learned, and you can always change your intervention. And like I said, it's really important to realize that some of these really small changes can lead to kind of big differences that can eventually lead to some of that sustained change. So before I turn things over, I just want to highlight, we talked again about missed genetics appointments and really focused on education and awareness, but CQI can really cover lots of different topics. You can talk about knowledge change for providers. You can talk about behavior change. There's really a range of different ways that you can implement CQI projects. We just happen to use education as kind of one of ours here for today. And like I said, the RGNs have done a ton of work around continuous quality improvement. You can see a couple examples of NIMAC things, and on the next slide, I'll show some links. We'll be able to send those to you guys so you can look at those for reference later on, as well as other RGNs have been really focusing on different CQI projects in their regions as well. So hopefully Erica at some point can share these links so you guys can see some example resources that we've used. Like I said, this Miss Genetics appointment was a great this genetics video was one that we used for our genetics appointment. And you can see some other ones that I pulled from some other places that really kind of run the gamut from, like I said, education to knowledge or some behavior change. And with that, I'm going to turn things over to Oksana and let her talk a little bit about the work that we've been doing lately in quality improvement in Puerto Rico. So go for it, Oksana.
Thank you so much. Can you hear me well? Everything's good? Great,
Yes.
perfect. So thank you, Melissa. I'm going to talk a little bit about our evaluation and quality improvement work in Puerto Rico and the US Virgin Islands. So kind of the main overarching objective of our work there is to increase access to genetic services in these territories. And in order to achieve this objective, we have established sort of three main goals, which are continually shaped by the local needs. These goals are to create local teams to help us plan and implement telemedicine and professional education programs. We also want to support intercultural and interprofessional education and collaboration between the territories and the continental states, as well as to design a culturally effective, applicable and appropriate telegenetics model that could be used for families in Puerto Rico and the US Virgin Islands. Next slide, please. So in order to understand and measure our progress in achieving these goals that we have established, we have been using a set of validated measures. And these measures, in this case, are usually in a format of surveys or assessments. We are using many measures in our NIMAC work. I'm going to be just presenting on one of them. We have used this measure, this specific measure in our work in Puerto Rico, and it's related to that first goal that I just described of establishing strong local teams in order to plan and implement our telemedicine and education programs. So this measure, it's called the 360 Engagement Assessment. It was developed by the ReachNet Clinical Research Network. And this assessment was designed to identify strengths and opportunities to improve relationships between multiple stakeholder groups or study teams. So we administered this survey to our NIMAC Puerto Rico team members, but before we actually sent out this assessment for our team members to take it, we modified it a bit to be culturally relevant to Puerto Rico and to be applicable to the work that we're actually doing there with our teams. This survey has about 20 or so questions. I believe it's 23 questions, and they really assess kind of satisfaction with roles among our NIMAC Puerto Rico team members. The questions also look at influence of team members and other stakeholders on our decisions that are made in Puerto Rico, as well as how well the team members are engaged in teamwork. So we will be administering this assessment twice a year. And we hope that this assessment will help us to continue to improve our teamwork in Puerto Rico to achieve that goal of establishing strong local teams to carry out work related to telemedicine and education. Next slide, please. So now we're just going to present some baseline data that we gathered from our NIMAC Puerto Rico team using this 360 engagement assessment. And I want to emphasize that this is just sort of baseline data. We will continue to administer this assessment, so we will be gathering more data from our team members. So here in this table, you can see some information about the actual stakeholders who took this survey. We had a total of 16 people who completed this survey, and they had very diverse roles on our NIMAC Puerto Rico team. You can see here that we had some members of the healthcare provider community. We had members of the academia, including professors and researchers. There were some members of the Department of Health in Puerto Rico. We had advocates for our patients and families, as well as family members and patients themselves. Some other NIMAC staff members also took this survey. So we had kind of a wide range of people who represented different NIMAC roles and responsibilities. Around 62% of those who took this survey were actually based in Puerto Rico, and everyone else was kind of spread throughout different states in the US. About 50% of those who took this survey have been with NIMAC between 1 to 2 years. Next slide. And just as a reminder, this survey again looked at such domains as satisfaction and understanding of roles on the team, influence on team decisions, satisfaction with engagement in teamwork, and kind of understanding more broadly of NIMAC's goals in Puerto Rico. So here are some results. 62.5% of survey 62.5% of survey participants reported that they had a clear understanding of their roles on the Puerto Rico NIMAC team. Over 56% reported feeling successful in their roles on the team. We looked across all survey participants, and we saw that between 62.3 and over 99% of the stakeholders who took this survey identified that they felt like they were extremely or very influential in the decisions that were related to the work that we do in Puerto Rico. We did see that 37.5% of respondents reported that advocates and patient or family members should actually have more influence on the team's decision. So that is definitely something we're going to consider in the future. Next slide, please. We also saw that over 60% of our respondents reported that all stakeholders were well engaged as equal members of our Puerto Rico NIMAC team. We wanted to ask some questions about trust and what are the levels of trust among the team members. And trust was assessed on a scale from 1 to 10, with 1 being low levels of trust and 10 being high levels of trust. So the mean trust rating was about 8.59. So those are high levels of trust that were reported among our team members. And finally, 81.2% of the survey respondents had a high or moderate level of understanding of our NIMAC goals in Puerto Rico. So these are kind of brief summaries that we got from the first 16 survey respondents. Next slide, please. Again, so I want to emphasize that our team, we will continue to administer this survey. This is just sort of preliminary data, and we want to continue to administer this survey so that we can look for opportunities on how to improve our work. Looking at these initial data, we already see that there are some opportunities for quality improvement, and there are areas that we can, put our efforts into. First, we're trying to think through on how to increase influence of our advocates patients and family members on our work in Puerto Rico. So like we saw, we had 38% of our survey respondents say that these groups should have more influence on our decisions. So we are definitely thinking about that. And second, how to increase understanding of NIMAC goals among our Puerto Rico team members, and how to help team members feel more engaged in our work. We saw that 63% of survey respondents reported having a clear understanding of their Puerto Rico NIMAC roles, but we want to bring that number up, and we want the team members to feel engaged in our work and have a clear understanding of their sort of roles and responsibilities on the team, and how we can sort of how they can be helpful and useful for our work in Puerto Rico and our team. So that's definitely kind of two areas that we're going to be looking at, exploring and helping us improve. And this came from this sort of assessment that we administered. Again, we'll keep administering to look for areas for improvement. Next slide, please. We wanted to provide a few more resources for you. So here you see the Phoenix toolkit. It's maybe some of you know it, but it's a web-based catalog of genetics related measures that can be useful in some quality improvement and evaluation work that you might be doing in the future, or something that you might be currently doing. We have some information on the slides from the Public Health Foundation on quality improvement, as well from the CDC on logic modeling, which is often used in evaluation, and some more information on the SMART objectives that Melissa previously outlined. Next slide. And I think this concludes our presentation. If you have any questions for us, we're happy to answer them. And I think we can paste our emails in the chat. I can do that. Thank you so much.
Great, thank you
Thank
very
you.
much. If anyone has any questions, we've got about 3 minutes left, so if you want to put those
Job
in.
on time.
That's right, perfect timing. You put them in the chat. You can also unmute yourself and ask directly.
And thank you, Erica, for putting the resources and links in the chat. And I assume it's just as easy to save the chat here as it's been in other sessions. So I think you can go ahead and click on those 3 little dots, right, to hit save chat if you want to go ahead and download those resources. But
And the
if you have
slides
trouble with
will
that,
be
let us know.
available online as well.
Yes.
Yes, because as soon as you leave this room, then the chat will disappear because you'll be going to another Zoom meeting. And that is something you can do, and we all will want to do very soon, to leave the room in a few minutes to do the cross-pollination session in the main session. So when I'm putting the link in chat now, and return to the main session, that's Zoom 1, where there'll be the cross-pollination, and all the presenters here are invited to do that. So we're going to actually be like folding up the tent here faster rather than slower, so that people come back to the main session.
Great. Well, thanks everyone for joining. Hopefully we gave you a little bit more information about quality improvement and some examples and some tools to get you going. We appreciate it.
Thanks, everyone.